The Assembly Budget Subcommittee 1, Health and Human Services, is now called to order. I want to welcome you all here to the hearing today. As most of you know, we will be addressing two major issues, 4120, which is Emergency Medical Services Authority, and 4265, which deals with the Department of Health, and 9 issues in that category. We'll begin with the Emergency Medical Services Authority, asking for a department overview. Issue number 1 and issue number 2. Welcome, and we'll begin.
Thank you, Madam Chair and members. I'm Dr. Howard Backer, the Director of the Emergency Medical Services Authority. This is Sean Trask, the Chief of our Personnel Division. And as requested, I'll provide you a brief overview of our department, our budget and the current budget proposal, and comments on our disaster medical preparedness. The EMS Authority is one of the departments within the California Health and Human Services Agency, and we're charged with providing statewide coordination and leadership for emergency medical services, largely accomplished through regulations and practice guidelines. We coordinate with 33 local EMS agencies that include 26 single-county agencies and 7 multi-county agencies that provide the day-to-day management for the EMS system. The direct 911 ambulance services is provided by a mixture of public and private entities, including volunteers in rural areas that operate in 338 zones. Pre-hospital emergency services are just one piece of an emergency care network that include hospital emergency departments and other services that provide one of the major healthcare safety nets. And the public now takes these services for granted as a guaranteed medical service. EMS Authorities is organized into 3 major functional areas. The first is our EMS Systems Division that reviews and approves EMS plans to ensure local EMS systems are organized to provide quality care and in compliance with statute, regulations, and standards. This division also approves the exclusive operating areas for EMS patient transport according to the legislative intent of our statute. EMS Authority provides statewide coordination and leadership for the trauma care system, which is designated and managed locally. And we're also developing now other regional specialty care systems for stroke and heart attack. We have responsibility for coordination of the pediatric emergency system to ensure that acutely ill and injured children receive the emergency and critical care services that they need according to their special needs. And in addition, we oversee the California statewide poison control system that receives about 300,000 calls a year through a toll-free number and provides services free of charge to both the public and other medical providers. One of our current EMS system challenges and initiatives is to oversee the transformation of EMS providers and agencies to an electronic patient care record that can be aggregated and analyzed at the local and state level in order to evaluate the EMS system and drive quality improvement of patient care. Secondly, our Personnel Division operates a state paramedic licensure program, conducts disciplinary investigations of paramedics, and sets scope of practice and medical training standards for EMS and public safety personnel. There are 60,000 certified EMTs, 20,000 licensed paramedics that respond to about 3 million calls annually, using 3,600 ground ambulances and 50 air ambulances to respond. They generally take the ill or injured to one of our 310 acute care hospital emergency departments that may be one of the 76 designated trauma centers. One of our new initiatives involves an application to the Office of Statewide Planning and Development, the Health Workforce Pilot Project, to test and evaluate the role of paramedics in expanded mobile health care roles to fill some of the gaps in local health care systems. And finally, the EMS Authority is designated agency for coordinating California's medical response to disasters, partnering with the Department of Public Health to lead our state's public health and medical emergency function in support of our local jurisdictions. We work with local and federal partners to plan for the medical impact of disasters and major events, from earthquakes to air crashes and from pandemic to drought. EMSA has developed a tiered response to medical surge and disasters. Our first tier is 42 ambulance strike teams that are dispersed in local jurisdictions, comprised of a lead supply communications vehicle that supports 5 other ambulances that would establish a field triage and treatment station for multi-casualty incidents within 1 to 2 hours. The second tier are California medical assistance teams that can be comprised of 5 to 40 members that can deploy within 12 hours and begin to treat patients in a tent or any standing facility using caches of supplies. Additional personnel can be pulled from our disaster healthcare volunteer registry that currently contains over 20,000 licensed personnel of all types, including the 42 locally organized medical reserve corps. And the third tier is our mobile field hospital program, which consists of 3 200-bed mobile field hospitals and the medical and administrative teams to staff them. They would provide general acute care hospital capability and may serve to either replace or supplement a hospital. Each of the mobile field hospitals provides an emergency department, surgical suite, intensive care, and other treatment wards, along with clinical support services. A note on our budget: the Governor's proposed budget for 2014-15 includes expenditure authority in the amount of $28.4 million and 65.2 permanent positions. Of this amount, $13.1 million is delegated for state operations and $15.3 million is delegated to local assistance. So you can see we're a small department despite some fairly major responsibilities. The budget adjustment under consideration includes the epinephrine auto-injector training program. SB 669, as chaptered, authorizes off-duty emergency medical personnel or lay rescuers to obtain and use an epinephrine auto-injector called an EpiPen in emergency situations after receiving training and certification. The bill requires the EMS authority to approve the authorized training providers and establish and approve the standards for training and certification on the use and administration of the epinephrine auto-injector. The EMS authority is requesting, therefore, 1 2-year limited term position and a budget authority for a $135,000 specialized first aid training fund that would begin July 1st, 2014, to address the new workload associated with the development and implementation of the bill. SB 669 permits the EMS authority to impose a reasonable fee on training providers for the review, approval, and certification of training, but we don't expect to generate any revenue until July of 2015. Due to this delay in revenue, we are requesting a $135,000 internal loan from an emergency medical services personnel fund for initial program startup costs. Then I was asked to answer 4 questions on our disaster medical preparedness. One was an update on the status of the mobile field hospitals. One of the most concerning impacts of recent budget shortfalls was the loss of funding to maintain these mobile field hospital assets. We've now consolidated the assets that were located in 3 different locations around the state to one single part of the state, and we're focusing on maintaining the ability to rapidly deploy at least one of the mobile field hospitals, with the others in delayed deployment mode, which would mean at least 3 weeks. There is one error in your summary in that there's only 2 hospitals that are stored currently at FoodLink. The other is stored at a Sacramento warehouse facility that we maintain. To return the program to its intended state of readiness and responsiveness to Southern California as well as Northern California would require about $1.5 million per year, which is a small percent of the initial investment. Efforts to find another public or private partner to fill the state funding gap have not been successful. We were asked to provide an overview of our emergency medical response capacity and how we compare to other states, and how we might compare today to what was in the past. The first priority in any disaster response is to save lives and minimize morbidity and suffering. California has made significant progress in preparedness with the support of the federal preparedness grants from the Department of Health and Human Services and contributions from the state in 2007. However, some of the gains have been lost or threatened by diminished funding. All response is based on the concept of mutual aid, from local to regional to state and then to federal. There will be more Katrina and Sandy level disasters, but there will never be another Katrina-type response with federal resources waiting for local invitation in the face of obvious need. California is considered a high-risk state for catastrophic disasters, with our major earthquake faults, risk of flooding, and attractive terrorist targets. Most notably, our major risk, earthquake, is a no-notice event, unlike hurricanes, which give at least several days' notice. We have been notified by our federal partners that funding of one of our 2 federal preparedness grants, the Hospital Preparedness Program, during 2014-15 will decline by 30 to 40%, and this follows a 30% gradual reduction over prior years. We're awaiting issuance of the grant award to determine the final state allocations. The EMS Authority and the Department of Public Health did some budget drills a year ago to assess priorities for about a 30% reduction in this grant. And although the grant would have the greatest impact to the EMS Authority that relies predominantly on this funding, it would impact the Department of Public Health because many of our programs were cross-funded with both public health and hospital preparedness funding. Just a few of the specific impacts on the Emergency Medical Services Authority are that we would lose about 10% of our disaster medical staff, which I consider our most important resource because trained staff is needed to manage emergency operations and implement response plans. We would not be able to sustain the investment in the medical surge assets such as our mobile field hospitals. We would seriously degrade our planning efforts and our exercise functions for our existing plans, because plans that are not exercised are simply binders on a shelf with insufficient knowledge of what's in them and their weaknesses. I've already noted some of the multi-casualty field assets that are currently supported by developed and exercised plans with our response partners. Public Health also maintains other assets, including plans and supplies for establishing alternate care sites that supplement low acuity care. California has not done a direct comparison with other states related to our capacity. However, as an example, Texas and Florida also have mobile medical teams, ambulance strike teams, tent-style mobile medical treatment facilities, and patient movement resources. But the disaster response requirements for any state are based on their hazard vulnerability analysis. We were asked to provide an update on federal resources in this area. We've actually made great progress in our coordination and planning with the federal government, with our National Guard, and with the Department of Defense that have embraced their civilian disaster support role. Currently, federal assets in our region include about 6 regional emergency personnel, 6 disaster medical assistance teams in California, and 1 additional team each in Arizona, Nevada, and Oregon, 1 disaster mortuary operational response team for our western region, a West Coast incident response coordination team that comes and helps us set up the emergency management. And there is a Health and Human Services warehouse in Rancho Cordova that has some DMAT caches, some medical caches, a portable morgue, and some communications vehicles and pharmaceuticals. California assets, though, figure heavily in the catastrophic event response planning and would be deployed much faster than federal medical teams and assets. Any federal field hospitals would come up from the Department of Defense, if they're available, and would require a minimum of 1 to 2 weeks for deployment. Additional assets could come from the Navy in San Diego that has shipboard medical facilities. The recent planning for our far northern counties after a Cascadia Fault earthquake and tsunami, which subsequently, coincidentally, was triggered last night, a 6.9 quake, rely especially heavily on state assets because the majority of federal assets would go to the more populous regions in Oregon and Washington, which would also be affected. And finally, we were asked to provide a timeline and cost estimate for the state to provide the legislature with a multi-departmental assessment and analysis of our emergency medical response capability. EMSA would be happy to work with the legislature and our Health and Human Services Agency and Department of Finance to determine how we could best respond to this inquiry, but I'm unable to provide you with any kind of meaningful timeline and cost estimate for a comprehensive assessment without further specifying the objectives and designating specific regions and event scenarios. So I do apologize for a lack of detailed analysis at this time for that purpose. Thank you very much, and I'll open myself to any questions you may have.
Thank you. Any other comments from LAO or Finance? Any questions from... Okay, fine. Thank you very much. I appreciate the fact that you not only gave the report, but you answered our questions.
Well,
So that
as
made
best
it
I could.
very effective. You dealt with item 1 and 2. Unfortunately, we can't vote to approve it. We will approve item number 2, but we don't have a quorum, so we can't do that. We'll just have to roll it over to the next meeting, but I don't think there's any controversy concerning that proposal, so thank you very much.
Thank you so much.
Thank you. Let's move on to our second item with the Department of Public Health. Yes. We have 9 issues in the Department of Public Health. So we'll begin with item 1, issue number 1, which is drinking water program transfer.
Good afternoon, Madam Chair and Member Dickinson. I'm Mark Starr. I'm Deputy Director in the Department of Public Health. And with me I have Medan Klein, who's my Assistant Deputy. And what we'll do today, and also I should introduce Ms. Liz Haven, who's with us from the State Water Board behind us in the audience. And she's the Director of Transitions there at the Water Board and is available if there's questions towards the end here. So Ms. Klein will provide an overview of the proposed transfer, then I'll provide a little more detail on the process as well as a couple quick updates.
Thank you.
Good afternoon. My name is Medan Klein, and I'm going to provide a brief summary of the proposal, which transfers the drinking water program from the California Department of Public Health to the State Water Resources Control Board. The goal is to integrate the state's drinking water and water quality programs under one organizational structure to best position the program for future demands for water quality due to climate change and population growth. Objectives of transferring the program are the following: to establish a single entity that will be responsible for water quality issues, to provide a comprehensive technical and financial assistance to assist communities, especially disadvantaged communities, to address water quality challenges, and to improve the efficiency and effectiveness of the water quality oversight, recycled water, and groundwater. This proposal transfers 291.2 positions and $200 million in funding. $5 million of that is general fund. The rest are special funds and federal funds. Most of the drinking water program functions that will transfer to the Water Board will be part of the newly created Division of Drinking Water, which will be overseen by a deputy director with public health experience and will be reporting directly to the executive director. The permitting and regulatory work currently performed at the district offices will continue to be done in the same way at the local district level. What will be different will include the funding programs, the state revolving fund, which is the federal capitalization grant, and the bond funds. This will be integrated into the Water Board's existing division of funding financial assistance. This will help communities that are having water challenges, water quality problems, by being able to access funding opportunities from one place. Also, the Recycle Water program will be more closely coordinated with the Water Board's permitting functions. And the Operator Certification Program, these will be managed jointly since they have similar logistics of conducting testing for water operators. Currently, CDPH has its own Operator Certification Program, and so does the Water Board. And finally, the emergency response. The current emergency response structure in the drinking water program will continue, such as the duty officer role, since the staff that perform these functions will be transferring to the Water Board. The drinking water emergency response will be integrated into the Cal EPA Emergency Response Management Committee. I will now turn it over to Dr. Starr for the updates.
Thank you.
Thank you, Medan. So I'll provide a description of where we're at in this transition process and a couple program updates. First, a really important part of the process is involvement of external stakeholders in a transition as significant as this one. And the administration employed several strategies in order to accomplish that. The one I'll speak about here, the most robust part of that process, was a task force that was formed, a reorganization task force convened by the secretaries of our two agencies in October and ran into December. And so every other week, up to 33 folks that represented various stakeholders across the state got together. And stakeholders include areas such as public health, environmental health, drinking water agencies, environmental justice, and other organizations, as well as some legislative staff. Once those meetings were completed, the secretaries also held a public meeting in January so that there were opportunities to also gain input from the public. So just the basic overview of the task force and the process, how it worked, included each of these meetings would have staff presentations on key topics. There'd be a proposal from the administration on how those topics were planned to be addressed in the transition and the new structure, and of course discussions and concerns and input from the stakeholders. The key topics that were discussed parallel those that are in your agenda packet, so I won't repeat them all here. All of them involve significant engagement by stakeholders. It was a very robust group. Some of these range from our regulatory program and the local primacy agency program, which is run by our county partners. About half the counties help us with the regulatory aspects of drinking water, and all the way through all the many topics listed in your packet to an important one, financial assistance for drinking water projects. And many of these are to help water systems return to compliance with drinking water standards, to make sure the water remains healthy, and they're especially focused on disadvantaged communities. And bridging across all these program areas, we had some pretty healthy discussions about the public health focus of the drinking water program and its roots in public health and the importance of sustaining that kind of approach as the program moved to the water board. So the outcome of all this was the administration put together proposals that addressed many of these concerns, based on the input from stakeholders and how the program would look at the State Water Board. Marianne Klein just outlined some of those changes and some of the things that are going to be different if the program moves, but also noted that the day-to-day operation of the program in many ways will continue unchanged, and the successes that have resulted from the operation of that program will be sustained. All of this will be detailed in a transition plan due out from the secretaries sometime this month. Along with that, of course, the real extensive work is done by staff in the program. Extensive internal work is done to accomplish a transition as extensive as this one. And so we have an umbrella transition team made up of representatives from both programs, and we also have over 10 sub-teams, again, represented by both programs. And they're really doing the heavy lifting to arrange for the transfer. And these sub-teams focus on everything from HR to IT to legal and legislative issues, financial assistance, and the regulatory program. So making sure all of that switches over appropriately. These teams have been working since late summer, and initially they worked heavily on the governor's January budget proposal and are now really heavy into the details and logistics of the change. So as we prepare for the transition, we're also continuing in CDPH to make great strides as a program. Our goal is to continue the process, the progress the drinking water program is making, and to assure the program will be ready for whatever changes are in store. I'll mention just a couple successes recently achieved by the drinking water program. As you know, and as is mentioned in your materials, last April we received a notice of noncompliance from U.S. EPA regarding the Safe Drinking Water State Revolving Fund. Their primary concern was $455 million of unliquidated obligations. That's federal funds that have been contractually committed but hadn't been spent yet, basically money in the bank waiting to be spent on projects. And recall that this is a reimbursement program, and projects and systems have to spend money first, incur costs, and then submit claims to us to draw that money out of the bank. So in response to this, we developed a corrective action plan. It was approved by U.S. EPA, and we've radically improved our disbursements as well as commitments of funds. In short, we've met or exceeded all of the requirements of the corrective action plan and all the deadlines to date. And we're on track to continue this throughout the duration of the plan, which will continue the transition to the State Water Board. It's been accomplished as a result of significant program improvements over the last couple of years, everything ranging from application processes and technical assistance to affordability assessments being done faster, and importantly, requirements for prompt claim submissions from the water systems. That gets the invoices to us so we can pay the bills faster. Some of the key results to focus on here today is that we have committed $265 million to drinking water projects. We did commit in just the last fiscal year as of June 13th. That was $25 million more than EPA required us to do. We'll commit another $356 million before this September 30th and during this year, and 75% of the projects on that list are small water systems. These commitments are important because they drive future disbursements, but we also had to address the current disbursements, and to that end, we've exceeded those targets as well. We've reduced federal ULOs from the $455 million that was in the notice to $369 million as of last June, and we're on track to disperse another $147 million in this fiscal year. In short, we're on track to achieving federal unliquidated obligation of less than $160 million, which is the EPA target, and all of the other deliverables in the corrective action plan on time. We've had several other enhancements to the SRF I think you're probably aware of. Most of these are focused on helping small water systems in disadvantaged communities, such as incentives for large systems to consolidate with small systems and assistance to form legal entities, having very small systems or communities come together to actually create a water system. So lastly, just a quick update on the area of our assistance to small water systems. Specifically, we implemented a small water system goal and plan in 2012, and then we identified 183 small water systems, many of them in disadvantaged communities that need funding assistance to address drinking water contamination, typically arsenic and nitrates. The added resources and efforts dedicated to this plan, and including last year's budget enhancement, have already paid dividends. To date, 22 of these systems have been returned to compliance, 40 are in construction or ready to begin, 75 are in planning or ready to begin planning, which is a precursor to construction, and all of them are engaged in our funding program. Nearly $99 million has been dispersed just for these small water system projects. In closing, we have strong collaborations with the State Water Resources Control Board, and these have become even greater during the transition planning as we've worked very closely towards this reorganization. And of course, we've been working very closely together on the drought response, not a topic here today, but that's also drawn us very close together. This will continue and will be essential as we jointly continue the significant progress and accomplishments of the drinking water program during and after the proposed transfer to a new home. And we're certainly available for any questions if you have them.
Thank you very much. Do we have any comments from LEO, the finance? We do? Good. Okay.
Amber DJ, Legislative Analyst Office. We recommend the transfer, but we have a few issues to consider as we evaluate the proposal. The first is related to the coordination of emergency response. In the Department of Public Health Director's role as the statewide public health officer, he has the authority to issue statewide and region-wide advisories in a drinking water emergency. So the State Water Resources Control Board will need to coordinate their emergency response plan in order to notify DPH when they need to use the state public health officer's authority in a drinking water emergency. The second issue is related to enforcement. In a 2010 audit, the U.S. EPA raised some concerns about the consistency of enforcement carried out at the local level by the local primacy agencies and the district offices. And the department has indicated that they've worked to address these concerns, but given that the data available is at the statewide level rather than at the region or local level, we haven't been able to evaluate whether these issues have been resolved. So based on this, we're recommending that the State Water Resources Control Board provide reports to the legislature in January of 2015 and January of 2016 on the outcomes of the transfer, including on permitting, enforcement, financial assistance, and emergency response and other areas of ongoing collaboration with DPH.
Thank you. Okay. Do you have a response to that?
Well, I could comment on the compliance report from US EPA in 2010. That was a program review that's done of the regulatory program specifically, and identified several areas where our district offices weren't always consistent. I think that's what this is primarily referring to. We have one of the great successes of our program is the field presence through these 23 district offices, but every area is a little bit different as far as the needs and geography and so on, and also the operation of the district. So we do everything we can to make them as consistent as possible, and EPA had identified some need to do that. So we've implemented a number of changes in response to that, and we meet quarterly with EPA. They don't have any problems with our regulatory program, and it's really one of the shining stars of our drinking water program is the regulatory aspect.